In this lesson, we'll continue our discussion of the chronic degenerative disorders by taking a look at something called amyotrophic lateral sclerosis. You probably know this a little bit better as just ALS, or you may have heard it as Lou Gehrig's disease. We'll then take a look at myasthenia gravis, which they abbreviate MG, and then Huntington's disease, which they abbreviate HD. So let's begin by looking at amyotrophic lateral sclerosis. Amyotrophic basically means muscle wasting, and then lateral sclerosis refers to the lateral corticospinal tract. And sclerosis means like a hardening, like a calcification of those fibers in that tract. And that's how they come up with the name. We see muscle wasting in the patient as a result of calcification of the lateral corticospinal tract fibers. As far as the cause of it, there's really no known cause. They have linked a couple genes that are on the different chromosomes to the disease, but really the etiology is unknown. This typically begins in the middle age, say from like 40s to 60 years old, and it does have a higher prevalence in males. I didn't put it here in the notes, just kind of you're aware. Typically, ALS does progress pretty quickly. A lot of times when somebody's been diagnosed with ALS, excuse me, they will progress very rapidly, and many times they die within a year or so. There are rare forms where somebody will last for many years, 20 years or something like that. But most people progress pretty quickly. So let's take a look at the pathophysiology. This is again a progressive degenerative disease affecting both upper motor neurons as well as lower motor neurons. Again, if you remember, upper motor neurons are the neurons that come from the brain, go down into the spinal cord, then they synapse with the lower motor neuron that say goes out to a muscle. So both neurons are affected. Loss of the upper motor neurons is going to be possibly due to astrocytes. If you remember, this is one of the neuroglia producing different neurotoxins. Some of the research is showing this, and then the toxin will damage the neuron. And what we see then is going to be spastic paralysis and hyperreflexia. If you remember from the lesson on cerebrovascular accidents, strokes, we had talked about spastic paralysis and hyperreflexia when the upper motor neurons are damaged. When the lower motor neurons are affected, well, then we're going to have flaccid paralysis, and the patient is going to have decreased muscle tone and a loss of their deep tendon reflexes. And so, again, it's a combination of upper and lower motor neurons being affected. Now, this is primarily a motor of problem, so sensory function is maintained, also normal cognition, right? So it doesn't really affect their thinking ability. And cranial nerves, number 3, which was the oculomotor nerve, 4 is your trochlear nerve, and 6 was your abducens nerve. These are all maintained. So even though the disease does affect lower motor neurons, these 3 cranial nerves are not affected, so the individual will have normal eye movement. A lot of times the reason for death is actually respiratory failure. You think about the diaphragm as a muscle that's stimulated by the phrenic nerve, right? And that phrenic nerve is a lower motor neuron. So that would definitely be a reason for death. So let's take a look at the clinical manifestations. Initially, we see weakness and atrophy of the upper extremities, right? Particularly in the hands. You'll see that the individual will lose some of their finger coordination and their dexterity. Then they'll develop stumbling and falls. They'll have muscle cramps or twitching from muscle imbalance, right? These the nerve impulses to the muscles is going to be off. Weakness and paralysis progresses through the body. Dysarthria, again, difficult, in articulating their words. Swallowing and respiration is impaired, requiring a ventilator, again, as that diaphragm gets weaker and weaker because it's not getting its normal nerve supply. They're going to have difficulty breathing. And again, swallowing involves the use of muscles, so that becomes an issue also. So as far as ALS, is really nothing that they can do. It's a progressive disease, so it's really, really supportive types of care, respiratory therapy, making sure the patient has adequate nutrition, speech, occupational and physical therapy, even psychological treatment. Again, you have these individuals, again, their brain is working, everything is working fine, but they're kind of like paralyzed, they're trapped, and it does take a toll on their psychological stability. Okay, so the second condition we want to look at in this lesson is myasthenia gravis, right? Commonly abbreviated as MG. This is an autoimmune disease, but this is a pathology that's occurring at the synapse between the motor neuron and the muscle, right? And that is known as the neuromuscular junction. The receptors on the muscle end um, are damaged, right? And are actually the immune system damages them so that they can't receive the acetylcholine, right? So this is an autoimmune disease impairing the acetylcholine receptors in the neuromuscular junction. Again, it's an autoimmune disease. We don't know the cause. This does affect females more than males. Typically, females show it a little bit earlier than males. Again, autoimmune diseases, I always like to think in females and during the childbearing years, so that's where they typically show up the most. In males, they show up a little bit later. You can see they're over the age of 50. So let's take a look at the pathophysiology. Since this is an autoimmune disease, we develop, or the individual develops, auto antibodies. Remember, these were antibodies against our own tissues, but specifically, these antibodies are going to damage the acetylcholine receptors. So if you don't have the acetylcholine receptors, that's going to prevent the muscle from contracting. Or if there's only a few acetylcholine receptors, then the muscle is going to be weak. So that's one of the main symptoms that we see. These individuals will present with skeletal muscle weakness. Facial and ocular muscles are usually affected first, right? So you'll see changes in their face, or even chewing. Like you'll, maybe having a bagel for breakfast. That becomes like a really hard thing for the individual to do because they have to kind of chew hard on the bagel, and they'll notice that their facial muscles are fatigued. Okay. Note, dysphagia and aspirations are significant problems. If you don't know, dysphagia is difficulty swallowing. And aspiration is, again, inhaling substances into the lungs. So let's take a look at the clinical manifestations. So again, since the pathophysiology is we're losing the receptors for acetylcholine, muscle weakness is going to be the predominant thing. Muscle weakness in the face and the eyes. The individual actually develops fatigue and the muscles become fatigued from the muscle use. There'll be impaired vision. Diplopia is double vision. Lidtosis is like a droopy eyelid, like the eyes look sleepy. They develop a monotone speech, difficulty chewing, difficulty swallowing. That was that dysphagia. As the muscles in the neck become affected, their head will droop forward, right? They can't even keep their head up, normal posture. The arms become weaker. And as a result of, again, just not normal movement and stagnation, upper respiratory infections are common, and they can't even cough, right? That type of thing to clear their respiratory tract. So one of the things that they can do, this is a condition we can treat with drugs. Just again, normal anatomy. In normal anatomy, acetylcholine is removed by this in the synapse by a chemical or an enzyme known as cholinesterase, or you may have learned it as acetylcholinesterase. And when we don't want a muscle to contract, acetylcholinesterase removes the acetylcholine. Well, by giving these individuals anti-acetylcholinesterase drugs, that's going to keep acetylcholine in the synapse longer so that whatever receptors are there are going to be stimulated by the acetylcholine. They'll be on glucocorticoids. That again helps to suppress the immune system since this is an autoimmune problem. Immunosuppressant drugs, and they even do a procedure called plasmapheresis where they remove those autoantibodies from the blood. Right, that gives some temporary relief. That's something that would have to be done on a regular basis. Okay, so that's our myasthenia gravis. The last disease that we want to look at that's a chronic degenerative disorder is known as Huntington's disease. You may have heard this as Huntington's chorea, right? But most of the times when they abbreviate it, they'll abbreviate it as HD. This is an inherited disease. This is an autosomal dominant disease on chromosome number 4. One of the issues is it doesn't show up until the individual's in their 40s. So and since it's a genetic disease, you pass it on to your children. So most individuals have already have had children by the time they're in their 40s, and now it's likely that a child may get it. So this is it's just kind of from a genetic counseling point of view, something that patients, when they have it in their family, is something they really should look into. As far as the pathophysiology, this is a progressive atrophy of the brain. Remember, atrophy means that tissues are going to get smaller, they're going to shrink, particularly in the basal ganglia and the frontal cortex. All right, if you remember from the previous lesson, we saw the basal ganglia with Parkinson's disease, right? So again, we said this ganglia here. Is involved with motor control, right, movement, so that they're nice and smooth and coordinated. So what's happening here as the brain atrophies, we lose some gamma aminobutyric acid in the basal ganglia. This is a neurotransmitter, and there's also a reduction in acetylcholine. Right? So we're losing two important neurotransmitters inside the brain. So the clinical manifestations we could look at as kind of early and late. Some of the early things we see are personality changes, even moodiness, like some mood swings. But this is the key. We start to see the patient become restless and they develop what they call choreiform movements. These are rapid, jerky types of movements. Just kind of the parts of the body will jerk. And we see that predominantly in the arms and the face. And there begins to be some intellectual impairment, right? That's possible. As the disease progresses, they develop rigidity, akinesia. Just think of that as the inability to move, personality changes, moodiness, behavioral changes. So you see they even get dementia. So this disease is not just a motor disease, right? It also involves a lot of behavior and personality type of thing. But you do see these choreiform movements, again, the jerkiness, and hence the name Huntington's chorea. So again, this is a genetic disease, so there's really no treatment. As far as diagnostic testing, they'll do DNA analysis, right? They'll look for that defective gene on the chromosome number 4. But like I said, there's really no treatment. So it's basically symptomatic therapy. They'll give the patient medications for choreiform movements. There's a bunch of trial drugs out there right now, different drugs for some of the behavioral changes. So it's really just kind of supportive care. Okay, so that concludes our lesson on all of the chronic degenerative disorders. Right, we had taken a look at MS, we looked at Parkinson's disease, we looked at ALS, myasthenia gravis, and Huntington disease. Those are some of the more common degenerative disorders. There's other ones out there that you could research on your own. And that's it. That concludes this lesson.